it can be viewed only by K. Venkatakrishnan, who has started the program. And we can speak to him, but he is not audible. When we speak, he cannot. We cannot hear him. But anyhow, we can start. If you give me 1 minute, just I will call him and then find out.
Okay, okay.
এইটো স্ক্ৰীন কৰিব লাগিব ন মই এইটো কৰাৰ লগে লগে আহি যাব না আৰু তাতে যাব লাগিব এইটো স্ক্ৰীন কৰি দিওঁ তাৰপিছত স্যাৰ এইটো ষ্টাৰ্ট কৰি দিওঁ মই এতিয়াটো মই যেতিয়া নেকি সিহঁতে এতিয়া নকৰোঁ সিহঁতে যেতিয়া নেকি মোক ক'ব এইটো আহি যাব না এইটো আহিলে ক্লোজ কৰি দিয়ক স্যাৰ ক্লোজ কৰি দিয়ক
ஜாயின் பண்ணிட்டாங்களா ஸ்டார்ட் பண்ணிடலாமா மீட்டிங்க You say we can start the meeting. இல்ல அப்படியே பார்த்து லைவ்ல சொல்லிடுங்க ஸ்டார்ட் பண்ண சொல்லுவா நம்பர் ஆஃப் பார்ட்டிசிபென்ட்ஸ் ஏதாவது பார்த்து சொல்ல முடியுமா சார்
ৰেকৰ্ডো কৰিব পাৰি ন এইটো ৰেকৰ্ডো কৰিব পাৰি ন পাছত মই নিজে ৰেকৰ্ডো কৰিব পাৰিম ন ইয়াত থাকি যাব আপোনাৰ কনফাৰেন্সটো হয়তো গোটেইখিনি ৰেকৰ্ড হৈ যাব ৰেকৰ্ড সেইটো মই নিজে কৰি দিম দে
Yeah, Dr. Someshwar sir, we can start the program. And
okay, thank you. Yeah, so sir, Dr. Shankar Kumar Das sir will start the webinar. So I'll give your introduction. Good evening, doctors.
Good evening.
I'm Dr. Rameshwar from Shield Healthcare as well on behalf of Shield. Thank you very much for joining today's webinar. I kindly request all the participants to post their questions in the comment box, and we will have a short Q&A at the end of the webinar. And good evening, Dr. Shankar Kumar Das, sir. Thank you for
Very good.
accepting our invitation, and it's an honor and my privilege to give an introduction like a humble doctor like you, sir. Yeah, actually, sir, don't need any introduction. Uh, Doctor is currently director at Swagat ART Clinic, Bongaigaon, Assam, and he completed his MD and FICOG, and he is organizing secretary at NEO GSCO on 2010, and also he is presently president at IMA Bongaigaon, and he have a publications of 11 publications in both national and international journals, and is a faculty in various national and international conferences. And with this, we welcome you, sir. It's our honor to have you here on today's webinar. And I welcome you for today's talk on updates in menopause. Thank you, sir. And over to you for your presentation.
Thank you very much. Can I share a slide now?
Yes, yes, sir. You can share the screen now.
Yes. So, very good evening to one and all. Let me thank first the SEAL, especially Mr. Satish Kumar, Venkatesh Sirji, Dr. Shamesh sir, and all these your functionaries of the SEAL that you have selected, and you have given me the chance, opportunity to speak before you, to get connected with my fellow in the Obs and Gynae department, and all the medical practitioners. I have observed that in the last your sessions, many speakers have presented wonderfully, excellently on the subject of menopause. So it's a great that I am given this opportunity today to speak in the same topic, that is on the menopause update in the menopause treatment. So So this is the part of the land I am hailed from, Assam. You all know that this Assam is famous for Kamakya temple. Everyone, when they reach Assam, they always visit Kamakya temple to have the blessings from the Devi. And this part is also famous for one horn rhino. And the festivals we do enjoy here is a seasonal festival, Bihu, and you know about this Bihu dance. And Assam is famous for its world famous, for Assam tea. The land I'm practicing here, it's a Bongaigaon. It's a semi-urban place. The patients I'm getting, basically they are from rural background. What I have observed in my practice that the patients with menopausal symptoms, menopausal age, they do not come with the typical symptoms of menopause. They rather come with the other symptoms, maybe of menopause also, indirectly or directly, which say there's infections, there may be prolapse, there may be menopausal bleeding. So our duty as a gynecologist become on more important on exclusion criteria, that is exclusions of the cervical cancer or endometrial cancer. By saying so, I want to mean that most of our ladies, women in the menopause age group are not aware regarding the availability of the treatment that we can give. So we have a lot to do on this part as a social worker to make them aware that yes, menopause is a part of your woman's life. They may have some sufferings. We are to ameliorate the sufferings, however it is, as a service giver. So yes, from the period to the no wrinkles, when they are having periods, there is no wrinkles, as stated. When they stop menstruating, they start having the wrinkles. The women's psychology is this: they want to grow no matter, but they do not want to shrink. This is the psychology we'll have to respect. And menopause is the end of menstruation, derived from the Greek word. Meno means menstruation, pause means stop. So it's a retrospective diagnosis. We cannot tell at what age the lady will attain menopause. When there is a consecutively amenorrhea for 12 months, then we'll label this lady as menopause. There are other causes also, amenorrhea will have to exclude, but in the group is important. The individualization of the case is very important. So I have said it is a part of the woman's natural aging process. So these slides, if you see, say menopause is a natural and normal transitions from the reproductive age to the post-reproductive age. If you see the slides, your precisely, the estrogen here is steady state, no fluctuation. Estrogen remains same. So there is no problem in reproductive age. When it starts fluctuating, somewhere it is more, somewhere it is less, these fluctuations and depletions make the sufferings in case of your menopausal ladies.
Doctor, may we request you to make the slide full, sir?
Oh, yes. Yes. Thank you. Thank you.
Thank you, sir. Thank you. It has come.
Yes, thank you. So regarding the prevalence of menopause symptoms in India, it is stated as that is around 47% in India. There are so many symptoms of the menopause, especially the vasomotor syndromes, which comprises hot flash, night sweat. So we all know what is vasomotor syndrome. And there may be psychological, dissatisfied with personal life, feeling anxious or nervous, experiencing poor memory, accomplishing less than before, feeling depressed, down. Physical symptoms, lots. There may be effect symptoms like flatulence, gas pain, aches in the muscle joints, feeling tired, worn out, difficult in sleeping, aches, like so many symptoms, even weight gain also. So when you talk about this prevalence, the one symptoms related to the vasomotor was 21.3% vasomotor symptoms, and physical is about 91.5%. So there's a big list of physical sufferings. So psychological symptoms also around 44.7%. And sexual symptoms as stated is 0, which I do not believe. Only thing is this: we do not talk about this, your sufferings in the sexual life. So, but nowadays people are talking, these are nice things. Quality of life and Bodhar analysis revealed that all those with menopausal symptoms also had their quality of life affected. We have observed that there are few percentage of the menopausal lady, around 15 to 20%, they do not have any symptoms. They are fortunate. But the moderate, maximum amount, they suffer from the moderate your menopausal symptoms. So this is an excellent slides I have stolen from the previous speaker. If you see the slides, you will find here is the estrogen secretions. The estrogen goes down and down, and somewhere around 46 or 47, the menopause attain. Immediately after menopause or just before menopause, the symptoms hot flash start, and the mood and sleep disturbance, then erogenal symptoms and skin changes start. This is your long-term disease. You start immediately after menopause, and then suffering goes and goes. Then cardiovascular disease, it starts after menopause, but for some years together, it remains in the subclinical state. Then the disease established, the sufferings become more in the cardiovascular disease. Same thing is osteoporosis also. Immediately after menopause, it remains in your subclinical phase. After 55 or 60 around, the osteoporotic changes becomes more clear and vivid. Same things with cognitive disorders. It starts immediately after menopause, but it remains in the subclinical regions. It becomes prominent after 65 years. This slide is important not only for the doctors, even for the service takers also. With these slides, if they can acquire knowledge, and they will be made aware when and how to take the care of these menopausal sufferings. Yes, terminology, we all know menopause, already I have described, that is a retrospective diagnosis. You do not know. When she attained menopause, after 12 months, we diagnose, okay, she is a menopause lady. So pre-menopause, before menopause, post-menopause, after menopause. So perimenopause is the transition period. Transition period. Some part it is also pre-menopause and some part is post-menopause. 3 years around probably it is in the pre-menopausal and 2 years it is in the post-menopause. This phase is important because it is a transition period. Here in the perimenopausal period, in initial part, the cycle is regular. After that, it starts irregular, to be irregular. That is the perimenopausal phase. So this is the probably dangerous time for the symptoms to surface, because there is a fluctuations of the estrogen that is the cause of the all symptoms and suffering. Say I will not, I already described. Yes. So if you go through the slides, you'll find the estrogen level. Main culprit of menopause is the depletion of estrogen hormone. So we know this pathology, what is the cause. Only how it decline. You see, somewhere in around the menarche, maybe 12 years, the estrogen essence in their level for 20 years around. At 29 or 30 years, it reaches the peak. After that, it starts descending for another 20 years. Sorry. So this is the age of menopause somewhere. You see 40, 51. It is written here. Anyway, so in this graph, just I want to note E2 level, even in the during the menstrual cycle, also varies from the proliferative to the secretory phase. Usually, it is taken on this third day of mens, so that we can standardize this your curve. One. Second is we do not include the E2 level in the pregnant lady. E2 level in the pregnant level is too high. So yes, regarding the estrogen receptors, we know as in medical students, when we take a drug, drugs goes through these intestines, then it act on the receptors, and it specifically it start giving the cellular functions. So same with these estrogens also. Estrogen, two types of estrogen hormones are there, as we know. Previously, we used to tell only alpha hormone, now alpha estrogen receptors. Now there is two types of alpha and beta. Both types of receptors are found in almost all the tissues of our body. I will tell you later on. So estrogen in reproductive organs, basically in the breast, helps in the healthy development of the breast tissue. So mainly, alpha receptors are more potent in the breast, uterus, skeletal muscles, and the liver. And the beta receptors are mainly found in CNS and the immune systems. Mr. Venkata sir, am I audible? Hello?
Yes, sir, you are audible.
Yes, sir, you're audible.
Okay, just I want to check because otherwise I'll be speaking. Okay, so this is very important. In uterus helps to repair the endometrium and prepare the uterus for the fetus development. In urogenital your organs, estrogen helps to maintain the lubrications of the vagina. It is very important because the fluid that is in the vagina, that is in uterus, helps in the transmit of this your sperm. So, and it helps in the sexual activities. So it maintains the integrity of the urethral epithelium. So there's a big chemistry, estrogen chemistry in the brain, because it helps to maintain the psychological well-being. Sometimes we call it a feel-good hormone. So in the heart, it regulates the cholesterol metabolism. In fact, in the liver, estrogen regulates the cholesterol metabolism. It increases the high density lipid, which is good lipid, and decreases the low density lipid. So estrogen decreases the incidence of heart disease, and it regulates the normal temperature and perspirations. I have already talked. In liver, yes. In bone, we'll talk later on regarding the bone. Estrogens prevents the osteoclastic activity. You know, there's a constant bone formation and bone resorptions. So estrogen helps in preventing the bone resorptions. So there will be balance. So in skin, it helps in the collagen synthesis, though it prevents the skin to become brittle. So if you talk about these estrogen utilizations, yes, estrogen hormone is secreted mainly about 90% from the ovary. Apart from the ovary, androgens, adipose tissue, breast also may secrete estrogen, and is utilized 60 to 70% in the reproductive functions and 30 to 40% utilizations in the non-reproductive functions. And I have stated the menopause, the root cause is estrogen depletions. Where from the estrogen comes? From the ovary, from the follicular development, granulosa cells. So in granulosa cells also, there is a beta receptors, we call it. In the theca cells, it is the alpha receptors. So this is a very beautiful slides which explains the pathology that happens in the menopause. There is a disbalance between the upregulations in the reproductive organs of breast and endometrium and non-reproductive, there is a down regulations. What is down regulation? Down regulation means number of receptors is less, the hormones is excess, and up regulations means when receptors are abundant and hormone is less. So this balance is to be maintained. In the perimenopausal time, we have already stated there's a fluctuations of the hormonal level. There's sometimes it is high, sometimes it's low. So this balance is dearrence. That's why the symptom starts. Yes, hot flash affects 85% of the menopausal patients. Studies found in the median duration is 7.5 years. Usually, hot flash stays 2 to 3 years, maybe less, but it may even remain 14 years, as stated by some researchers. So only 25% seek medical leave, but I hope it will be increasing with these activities that is done by our medical fraternity and the service givers. So hot flash may last already 7 to 11 years as per the Journal of Midlife Health. So frequent hot flash were associated with decreased memory performance. So we are all acquainted with these problems that happen to the postmenopausal lady. This is Cooperman index, all you know, already discussed nicely by our previous speakers. These are the list of symptoms, discomforting symptoms rather. Vaginal dryness due to the depletion of the estrogen, you're affecting your sexual health, hot flash, night sweating, paresthesia, insomnia, nervousness, melancholia, dizziness, fatigue, arthritic pain, formication. Formications means some as if the insects are crawling beneath the skin. They will describe like this, and there may be palpitations, and yes, there may be headache also. We call it when there is no symptom, 0. When it is mild, moderate, severe, very severe, we talk 0, 1, 2, 3, 4. Like that, we score. If the score is more than 20 or 25, we can label this patient is having really severe symptoms. So vasomotor symptoms comprises hot flash and night sweats, Vulvovaginal atrophy, we have discussed psychological symptoms, mood swing, insomnia. So, our family members, whoever with the postmenopausal lady, should be made aware about these sufferings of the postmenopausal lady. The lady may have sometimes hot feeling, sometimes cool, sometimes they will be shivering. So if they are taken care of this sort of thing, then definitely the family member will be very much helpful to this menopausal lady. Increased cholesterol level, already said. Uh, then osteoporotic change, there's an osteoclastic activity in absence of more osteoclastic activity in absence of estrogen. So yes, upregulation of the estrogen affinity on reproductive organs during menopause. I have said some things. Upregulations means there is more receptors. So when estrogen will come, it leads to estrogen stimulations, and it will cause this abnormal cell division, mitogenesis of the carcinogenic cell, MCF7 cells. So that's why upregulation of the estrogen affinity is the cause of carcinogenesis. The proliferation can lead to the breast cancer if it happened in the breast, and there is a risk of endometrial cancer same way. So long-term complications, yes, cancer, already we have discussed. And along with this, there may be stroke, CVA, with this we have missed one slide. Okay, no problem. Okay, so the COVID has taught us how health is very important. So during the COVID days, we learned many things. In initial part, we thought the pathology is infective. Later on, we have diagnosed, no, it is an coagulative disorders only. It makes this coagulation profile derail. With this estrogen therapy, if you put someone in the menopausal hormone therapy, so with this estrogen therapy, there may be exacerbations, there may be increased risks of the thromboembolic phenomenon. So we have stopped giving this estrogen therapy during the COVID days. At least the patient should recover nicely, and she should be or he should be perfectly okay on this coagulation profile. Same things, coagulability. Yes, bone health and menopause. Issue is bone pain. Sometimes the menopausal lady complain there's a bone pain. There's due to the osteopenic changes, there are less estrogens, so there is increased fracture risk. Yes, there will be bone mineral density will be decreased. With this, with this, there will be increased chance of fracture. Your bone mineral density scores, if it is less than 2.5, there will be more chance of fracture. So as a solutions, we are to give this your calcium, vitamin D suppletions, and there will be increase in osteoclastic activity. I have said there will be increase in ALP, decrease the bone mineral density. So what are the options to treat this sort of patients? Hormone, yes. When there is a depletion of the hormones, we have to give this your replacement. Somebody may be you're arguing why replacing. It is supplementations. Yes, it may be supplementing therapy also. So hormone estrogen usually we give, but which types of estrogen you give, it whether natural or synthetic. Natural is definitely best, but it's not very much available. So conjugated equine estrogen, that is a mixture of the estrogen we used to give. Later on, we started giving 17 beta estradiol, hemihydrate, estriol. So, and Tibolone is another synthetic estrogens, steroidal synthetic estrogens. It's a beneficial effect as an hormone therapy. And estrogen progesterone combined preparations we can give, but we have come to know that ethylene compound is carcinogenic very much. So we started reducing the estrogen compound, but later on we supplement, we add your progesterone, medroxyprogesterone. Later on we have come to know medroxyprogesterone is carcinogenic. We start giving this hydroxyprogesterone. Now we are giving microgenized progesterone. So with this knowledge, we are changing our pattern, we're changing our treatment. But with this hormone therapy, you should make your patients aware. Even your patient will make aware. You will point out why you are giving the hormonal treatment, because it is carcinogenic. So you will have to answer. So you will have to weigh up the advantage and the disadvantage. You will have to make a good counseling with this patient. Okay, immediately after HRT, the symptoms may be ameliorated, but you are buying a cancer risk. So this is also not justified. That things you will have to counsel. Apart from hormonal and anti-osteoporotic and these your other options, I want to note here that yes, lifestyle change is also important. It means that taking the care of your diet, reducing weight, taking your care of these other diseases. So this is also important. It is not mentioned in this slide. Anyway, anti-osteoporotics you can add as calcium, vitamin D. Yes, selective estrogen receptor modulators. Relaxifene is excellent drugs. It will block your estrogen receptors. It will sit in the estrogen. It will not allow the other your estrogens to come. So it's a selections. It is somewhere it will be agonist. It will be antagonist as per the tissue specificity. So this is an excellent drugs. We do need more research on it. It can be very beneficial. Yes, soya isoflavones we have prescribed a lot for last few I will tell few decades even. So it is stated that is an anti-estrogenic. We were taught that isoflavones has more affinity for these beta receptors, estrogen receptors, and beta estrogen receptors are anti-tumor. So we are taught like this. So we started giving the isoflavone. Yes, the result is in front of you. And this is another bisphosphonates drugs we started giving as an anti-osteoporotic agent. So next is non-menopausal hormone therapy options, Estrogen 100. This is an herbal product. People are nowadays talking about this Estrogen 100. We'll be talking about this Estrogen 100 later on. Yes, drawbacks of the HRT. We have already talked that endometrial cancer is our focus. If we give your hormone replacement therapy, there is increased chance of endometrial cancer, there is increased chance of breast cancer, there is an increased chance of venous thromboembolic disease, and the lipid profile also, and the increased incidence of the gallstone. So these are the concerns after giving the HRT. I have talked about this soya. We have already prescribed many studies, non-conclusive evidence of improvement in the menopausal symptoms in 43 randomized trials. The isoflavones are not suitable alternative to the HT, hormone replacement therapy. But this is also fact that in the Japanese or Korean, they are taking lots of isoflavones. The incidence of cancer, breast cancers, endometrial cancer is less in their country. So I think more researches are required in this field. This is an paper which concludes daily administration of tablets containing 200 milligrams of soy isoflavones for 2 years did not prevent the bone loss of the menopausal symptoms. So what is the ideal menopause solution? Yes, it's regulate the endogenous estrogen to the non-productive reproductive organs and reproductive organs, and should offer symptom relief as good as hormone replacement therapy. So there should not be any cancer, there should not be any thromboembolic risks and stroke which is associated usually with the HT hormone therapy. This is explained. If this balance can be maintained, maintained, then our concern will go. So many medical hubs are coming in this field to be an answer to ameliorate the menopausal symptoms and the sufferings. Cinnamic acid, S-methyl ester, dicarcinol, anzilate, they are all from the plant. So it's nice. As an allopathic doctor also, I don't feel hesitating to talk about your plant. You cannot make me stop talking about ginger, turmeric, is it not? So we can talk. If there is a benefit, there's nothing wrong, so we can accept it. So there is so many studies they have made that your cinnamic acid, angelica, gigas, herbal formulations are really helpful to ameliorate the symptoms and sufferings of the menopausal ladies. Estrogen 100 regulates the estrogen affinity to the estrogen receptors. There will be no risk. That is the important things we want to hear. There is no risk of cancer. So affinity to alpha and beta receptors, you see, and it inhibits the MCF cell 7 cells. So that's why the cancer risk is reduced. So non-estrogenic hormone regulator. It is a hormone regulator, but it is beautifully, it is a non-estrogenic. So they have done some studies, one in USA, two in Korea, and they have published in renowned journals, and both objective and subjective parameters validated extensively. So evidences are there: vaginal dryness, hot flash, mood swings, bone pain are relieved within 7 to 14 days. This is up to you how you conclude from your practice. They have concluded subject on Estro-G 100 groups had significant reductions from 10 out of 12 Cooperman index symptoms. So this is already explained that if you give your Estro-G, if you give your hormone replacement therapy also, there may be reductions in the osteoclastic activity. But here, estrogen is working, and the alkaline phosphatase, which is increased in estrogen deficiency, with this estrogen, there will be decrease. So bone mineral density will be increased following the treatment of the estrogen around 12 weeks. So biochemical evidence says that bone mineral density increases, serum growth hormone increases, serum osteocalcin decreases. Nice. Serum triglyceride decreases, wonderful. And serum ALP, alkaline phosphatase, decreases. So Estrogen 100 has been proven effective in improving the menopausal osteoarthritis in 2 clinical studies. There was a more significant improvement than the placebo-treated group and total reported menopausal symptoms, including joint pain. So regarding the effectiveness and safety profile of the estrogen, yes, it is safe and effective, they have concluded. Yes. Your Cooperman index reducing, hot flash is reducing. Results and conclusions: Estrogen 100 for 12 weeks statistically significantly improved the quality of life. 9 different symptoms improve: hot flash, night sweats, paresthesia, nervousness, melancholia, vertigo, fatigue, rheumatic pain, and vaginal dryness, pre and peri and postmenopausal women. Insomnia is improved. So no adverse event were reported with Estrogen 100. So it is safe and effective herbal formulation as stated. So even estrogen is stated to be very helpful in the menopausal lady following hysterectomy and oophorectomy. But if you talk about this HRT, hormone replacement therapy, many people may ask me whether you will use this your hormone replacement therapy in case of premature menopause. Yes, you can use, but this is also a fact. This sort of patients are very much prone to develop breast cancer, endometrial, or is endometrial no matter, and breast cancers. So you should take care of these things. But estrogen you can use, but if you use HRT, you should use after the corresponding menopausal age. If you are to use also with the counseling, with this your consent from this person, you should use for the short term with follow-up screening of the breast. So, though we call the estrogen is doing its functions of the estrogen, but in reality we have got it is not an active estrogen. There's no effect on the E2 level and FSH. We know this in menopause, FSH level is significantly high. It is above 40 and E2 level is less than 30. But with estrogen, we do not see any difference in this level. So no toxicity, even you use 2 grams per day kg weight. No specific abnormal symptoms were observed except the compound color diarrhea on the day of administrations of the estrogen. So it's a solutions, safest options. Yes, it is accredited in US, Canada, Europe, and Asia. Little bit, I would like to talk about this menopausal pregnancy. In the first part of my lecture, I have said the perimenopausal woman. In the first part, the cycle is regular. In the later part, the cycle becomes irregular. Sometimes you will get double ovulation, second ovulation, even in the 30 days. So you cannot ignore the possibility of the pregnancy even in the perimenopausal age group, but premenopausal age group, you can tell. Some part of the perimenopause in the premenopause and some part in the postmenopause. Once the lady attains the menopause, there is no chance of pregnancy from her own egg. Yes, she can be pregnant with the ovum donation. Again, she can be pregnant if her oocytes already frozen. So you can make her pregnant. So in these things, my feeling is this: as if ovary grows older faster than the uterus, because there is the receptibility, an embryo receptibility remains even after menopause. If the pregnancy happens also, there will be lots of complications from the miscarriage. There's every chance of miscarriage because chance of aneuploidy is very high. Chromosomal aberration is very high. The quality of the oocytes, even if you take also from the donor, there will be high. Even in perimenopausal, the quality will not be good. So that's why the miscarriage rate is very high. If during pregnancy there may be hypertension, abruptio placenta, your placenta previa, gestational diabetes, hypertension, so many things may happen as an anticoagulant, and there may be low birth weight baby. So you should make aware to the lady who have conceived in this menopause or perimenopause. So I am not a good supporter of the pregnancy after 50 years, even by the ART also. Yes, lab is required. DNA may be optional, but there should be cut-off age to be mother. Yes, we have seen that our life expectancy of a lady, an Indian lady, it's going up and up. It's about 80 years. So if she attains your menopause at 45 or 46, 30 years she is to live in this phase, menopause. So 1/3 of her life is very important if we can give quality life. I have stated in the introductions, their psychology is that they can grow old, but they do not want to shrink. But this is also reality. These women never shrink with their care and love to us. So growing old is natural, but feeling old is not good. Not. We'll have to make it proof in their psychology. Thank you. Hello. Hello.
Thank you, sir, for
Welcome.
wonderful presentation. It was
So
excellent and you, sir.
I have finished my
Hello.
presentations. So
Yes, sir. Yeah. So if you allow, then we'll have a short question and answer session.
yes, yes, yes.
I'll read the question from the delegates from the chat box. So we have a first question, that is whether genitourinary syndrome is underdiagnosed and undertreated in menopausal patients.
Definitely, it is not diagnosed. Is underdiagnosed in most of the cases. They do not come. Maximum cases remain undiagnosed when the severity of the conditions goes beyond control. In some cases they come, particularly in rural background patient. But in we have seen nowadays our menopausal ladies are talking very openly, the many symptoms they are suffering, incontinence during laughing, coughing, they your said your urine, these sort of things they are discussing. So they are coming to the doctors to take care of it, to get treated. So these are the things are coming: vulvovaginal atrophy, sexual problems, in your loss of libido, painful intercourse. These sort of things people start discussing. So it's nice things, but still, by and large, I will tell it is underdiagnosed.
Thank you, sir.
Welcome.
We have one more question.
Right.
Sir, any tips for coping with menopausal symptoms in dietary?
Any
Any
tips?
dietary strategies to decrease the tips
Diet
for
what?
coping with the menopausal symptoms? Yes, sir. In regards to dietary.
Regards to diet. Yes. The general concept is really helpful. Um, they should be supplemented with calcium, vitamin D. So dietary products, milk and other is very important, and they should take sufficient amount of vitamins. And vitamin D is important. If they take the vitamin D from sunbath, it is more good, what I believe. So we have observed that our ladies are deficient in vitamin D level about 70 to 80%. Nowadays it is increasing. Now vitamin D is thought as an chemoprophylaxis of the almost all the diseases. This is the understanding of the today. So same case with the menopausal lady. So they should take care of the vitamin D. They should take sufficient amount of citrus food, and many they should avoid. I will not tell. They should avoid the non-veg. if they take the vegetarian food better. They should quit your smoking. They should not take alcohol, because we have found that smoking causes premature menopause, and it will increase the symptoms of the menopause. Though they should quit the smoking and alcohol, and they should take care how to reduce the weight. Again, the diet will come to play in reduction of the weight. Thank you.
Thank you, sir. We have one more question.
Right.
What are the frequent laboratory workups for a menopausal patient?
To be very polite, we do not do any investigations to diagnose menopause. With the simple history, it is sufficient to diagnose menopause. But if you are to label someone menopause, you can go with some symptom, with some your investigations. Yes, you can do serum estrogen level. It should be less than 30. The follicle stimulating hormone, that will be significantly high, because it means that ovary is not producing estrogen. So FSH hormone will be secreting to affect on the ovary, but in turn the FSH will be raised. So significant rise of FSH is the hallmark to label a case with menopause. But history is more important than this level.
Yeah. Thank you, sir.
Welcome.
Sir, there are, apart from questions, there are appreciation messages also from the delegates.
Thank you. Thank you.
Sir, I don't find any additional questions in the comment box. So if you allow me, then we will close this webinar.
Yes. Thank you very much for giving this opportunity to speak in this wonderful digital platform. Anyway, thank you, Satish ji, thank you, Venkata ji, Dr. Shamesh, to cooperate with me. Thank you. Thank you. We can leave, no?
Thank you, sir. It's our honor to have you here, sir. Yes, sir. And I thank all the delegates for participating in the webinar. Many thanks from the Shield.
Thank you.
Thank you very much, sir.